Sawadee Cup, hello and welcome to what is effectively a re-recording of a free webinar that I created just last weekend. I conducted two free webinar sessions, one with a US-centric time frame and one with a UK-Australia-centric time frame. It was my intention, and I did advise people participating in that webinar that I was going to give them an opportunity to have a recording of the session. Unfortunately, I didn't realize when I was recording that the consequence of me recording live meant that I had the faces of the participants rather, in the recording itself. So in the spirit of fair play, I didn't want to necessarily put those people on the spot, as it were. I think they are entitled to their privacy. So I have elected to effectively re-record the material. So clearly this is not a live webinar. This is a standalone recording. But effectively, I'm going to be showing the presentation that I made at the webinar, and a number of very pertinent and relevant questions were asked by participants. I have a reasonably good recollection of what those questions were. So I will endeavor to add that information as we proceed through the presentation on an ad hoc basis. The intent of this material, unashamedly, is to assist me in the promotion of the new female-specific or female-centric educational website, enhancewomen.com. I have long had members of the female athletic community lament to me the challenges with them finding high-quality educational materials specifically geared towards female enhancement, and I completely agree with them. I have never really understood why that is, and as we go through this presentation, one of the things that you'll come to appreciate is that it's not because there's not fabulous data for us to consider in the process of forming our opinions about the application of enhancement practices with women. One could pretty easily argue that there's actually some better data in women in some areas than we have available for men. It's certainly true that in the domain of testosterone replacement therapy, that there are, really thousands of studies today, well in excess of 2,000 studies today that relate to the application of testosterone replacement therapy in men. Far, far, far less data is available in the clinical application of, well, specifically, I would say testosterone replacement for women. There's quite a lot of data in regards to HRT, and we'll talk a little bit about that in the presentation. But the great irony, of course, is that there are a couple of cohorts that we have really interesting and really thought-provoking data to consider that are available to women that are not available to the males. So we'll get into that. We'll look at that. And as I said, I think if you haven't seen some of that data before, you're about to be, a little surprised, a little shocked. I certainly was on the first occasion that I, kind of immersed myself into the female-specific literature. I was very, very pleasantly surprised about the quality of data that we have to consider when we're forming our opinions. Okay, so let's start with today's presentation. Now, there are a number of key points that I intend to address in this presentation, 8 of them. Let's start with asking the question, so what problem are we trying to solve for here? I always try to relate to people whenever I talk about the application of enhancement products. I am not trying to talk about that works and that doesn't work. I think it's fair to say, and this is probably as relevant for women as for men, in the 1960s, 1970s timeframe, we really didn't know what we were doing. We were just trying to understand a lot of these drugs that had been relatively recently brought to market. A large percentage of the drugs that make up the staple of our use today kind of came in at that time frame, and we were trying to understand how do we apply these for effect. Not a lot of great insight into application in that time frame, but I think it's fair in the sort of 80s, 90s, and 2000 time frame, we figured out what works and what doesn't work. These discussions that we're having in 2021 are not about that doesn't work. These discussions are about the consequences of use, what we're learning more and more about really every day is the consequences of abuse/use, however you want to position it, and what we can do potentially to mitigate risk. Okay, so again, this is not about that works and that doesn't work. I think we're well past that point. Things that don't work are not really represented in our tribal behaviors. This is about, look, if there's 2 or 3 alternatives or 2 or 3 pathways that we might take, is it plausible that one of those pathways might make a better choice in terms of efficacy and safety profile over the others? Okay, so we're going to talk about the long-term abusive consequences of the use of performance and image-enhancing drugs, with special regard to the key differences between men and women. Okay, I want to talk, as I said right at the opening, about the current state of the quality of the educational material that's available for women on the safer use of enhancement practices. Obviously, it is my opinion that that is poor, at the very least, that there is an opportunity in the marketplace for me to come in and create a resource that ideally will be adopted and valued by the community. Okay, we'll talk about the different needs of men and women in strategic cycle planning, including the difference between peak value of drugs and cumulative lifetime exposure. So acute application versus long-term cumulative exposure. Talk a little about compound selection. This is where we really start to get the interest of most people that are interested in. So what drugs, when, which PEDs would we consider more female friendly than others? I want to talk very briefly about quality of supply, and then have a bit of a discussion about some examples of possible cycle design for women from very moderate to rather advanced users. And then make just a couple of very simple recommendations. And many of the things that we're going to be talking about today are quite high-level discussions. There's a little theory, there's a little speculation, there's a little opinion. The last chapter that I want to talk on here are really some very simple things that we can literally do tomorrow that have the potential to help women in regard to minimizing their risk of exposure to masculinization or viralization effects due to the consequences of application here. So let's start with the question. So what is the problem that we're trying to solve here? Okay. Now, what I hope that this talk is going to deliver to you is not this idea that I'm going to teach you everything that you need to know about the application of enhancement for women in a single presentation or in a single webinar. I don't think that you could say that that's true in any area of life. So this presentation is really about putting some flags in the sand, as I like to say, or creating a framework or an outline, exposing threads for you to pull on that you might wish to learn more about. Now, maybe that means that you're going to roll up your sleeves and dive into the literature yourself, or maybe you'll realize that at this point in time, you need to hire a coach to help you with that journey. About 50% of my clients are indeed coaches that are looking to improve their understanding of the application of these types of tools for their own clients. So in short, what I would say is, if you get to the end of this presentation today and where you end up is you end up with effectively more questions than you have answers, I would actually, rate that as a good thing, okay? Because I have literally spent, tens of thousands of hours immersed in the literature. I'm 53 years old. I've been training for over 35 years, and I'm still learning new things every day. And I still have questions that I'm looking for answers to. You can't possibly learn everything you need to know in a single sit-down session like that. So, as I said, depending on who you are you a coach? Are you an athlete? Are you a beginner, intermediate, experienced user? I expect you to have different takeaways from the presentation. That's the intent. I'm fairly certain that there would be no one that's going to watch this that would gloss through this and said, I know all of that. I have, as I said, presented this on 2 occasions to individuals that I consider to be very knowledgeable about this subject, and all of them have kind of come back and gone, that was very thought-provoking. I didn't see it through that filter or that lens historically. So I'm fairly confident in saying that there's going to be value here for everybody, from the beginner to the intermediate to the extreme advanced user. Okay, now the one thing I would do is I would caution you right up front that if you choose to follow me and you read the content and the material that I produce, not necessarily even today's presentation, but in general, that I'm going to basically present information that at times makes individuals uncomfortable. I'm going to I show you this graphic here for a particular reason. It is the photograph of the testicles of a normal, healthy person, normal size on the left, and the visual consequences of testicular atrophy in a 30-year-old anabolic and androgenic steroid user on the right. Now, the reason I show you this is most men have heard of the consequence of testicular atrophy, but I'm the kind of guy that will show you pictures of things. So the point I'm making behind this is not to deliberately offend or upset, but just to make you sure you understand I don't sugarcoat things. I try to represent things to be factual. And if that makes you uncomfortable, that's your problem, and you can move on and you can bury your head in your sand if you want. I'm going to be talking about truthful things as we move forward with this material and in the future. Okay, so I just caution you up front. Nothing to be concerned about today, but I talk about things like changes to sexual anatomy very openly, very transparently, where most people, it is a taboo subject. Okay, so ask really anyone, ask anyone that's ever heard about anabolic steroids, and they will be able to relate to you that there are a list effectively of commonly reported side effects that are attached to the use of these androgens, and those side effects do vary by sex, male versus female. These is a graphical representation of a number of commonly reported side effects, and I don't necessarily disagree with any of these, but we will be talking about the real dangers of the applications of androgens in the next slide. These are, for the most part, cosmetic. Talking about things like acne, mood changes, temporary sort of thing, insomnia, blood pressure elevation, gynecomastia, sexual dysfunction, testicular atrophy. The biggest takeaway, in my opinion, from this graphic is on the far right-hand side of the screen, you can see a red box drawn around that pylon there. And what that's designed to indicate is that less than 10% of individuals that expose themselves to this class of drug would report that they had no side effects over the duration of their career exposure. In other words, if you open this door, you really need to be prepared. You need to accept the fact that this is really a conversation about to what magnitude are you going to be impacted rather than is it likely to happen. Very rarely, very, very rarely do people expose themselves to these drugs and walk away at the end of that exposure experience without any reported consequence of application. Now, what I spend a great deal of time talking to men about, let me have a sip of my coffee here, sorry, is what I consider to be the real risk of exposure to performance-enhancing drugs. And that is not acne and gynecomastia. I'll be very honest with you, if you know what you're doing, you can modulate those effects very simply, very easy. They're relatively easy things to address. The really important aspects here are addressing the 6 different androgen toxicologies. So cardiotoxicology, the heart, the liver, the kidneys, the central and peripheral nervous tissues, and basically the vascular system, and what they call hematoxicology, which is basically blood constituents. Now, we are going to be spending some time talking about the differences of impact on men versus women. And this is the separation point where we would begin that journey. I spend a tremendous amount of time talking to men about these issues and explaining to men, and I'm not trying to dismiss things like acne, but it's a pretty easy things to fix, okay? What you need to protect is your heart, your brain, and your kidneys. Now, one of the luxuries or one of the benefits that women have is because they are so exquisitely sensitive to growth promoters, androgen in particular, the dosages that they need to expose themselves are very, very, very small compared to the doses that is in common deployment in men. And the consequence of that is that we have different potential risks. Now, one of the cohorts that I spoke about, in other words, groups of people that we can consider when we're looking at the long-term safety of both physiological and supraphysiological doses of testosterone, is the group of people we refer to as female to male transgender patients, people that are basically born female, that identify as male, that are going through a process of very intentional, deliberate changing of their physical appearance with the support of their endocrinologists and a medical team. And there's a couple of tools that they use to do that, but straight out of the box, the first domain is the elevation of androgens to the levels that we would see in men, okay? And the tools that they use to do that, quite bluntly, are typically testosterone. Testosterone injections is the first line treatment for this condition. Okay. Now, the most interesting thing about this process is we're taking biologically healthy young women, okay, and exposing themselves to levels of androgens so great, all right, that effectively you are forcing the changes that every female is trying to avoid. So in other words, the outcome that this community is seeking, changes to voice, changes to basically hair, like body hair, facial hair. These are the things that female physique athletes are really wishing to avoid. And yet this cohort are deliberately and intentionally seeking their outcome with the support of, as I said, their endocrinologists. And that is fascinating. And that is a group of people that if you are a female and you're interested in the elevation of androgens for performance enhancing, is something that you should be very open-minded to. I have had women over the years, struggle to identify with this group because they say, well, I'm not transgender. I'm not talking about that. I'm talking about the elevation of androgens. Now, the first big takeaway was this: despite the fact that we elevate androgens in these women's to such a magnitude that we start to see very profound physical changes and changes like voice frequency, there has been no evidence of increased mortality, breast cancer, vascular disease, really what we would call major health problems really don't present themselves in this group from the comprehensive searches that have been done on literature trying to answer this question over the last really 40 odd plus years. Okay. And so that bodes very well for women that are wanting to understand the consequence of application of these drugs at less than those doses. And you can see here, this is the advantage that perhaps female have in the first instance, is we have a group of people using far, far, far too much with the support of the medical community, and basically, for want of a better word, getting the thumbs up in terms of long-term health application, with the singular exception of be very careful about the excessive virilization and masculinization that they're trying to, induce, because that's, that's the outcome to the elevation of androgens ultimately. So as I said, women who are interested in testosterone replacement therapy clearly are concerned about health consequences of in application of these androgens. We can use the long-term data on the group of female to male transgender patients as fairly reassuring data that supports the use of much lower dose testosterone, saying, look, it appears to be relatively well tolerated and relatively well safe, apart from those aspects of virilization, which include deepening of the voice, change of sexual anatomy, and in general masculinization and potentially some conditions like androgenic alopecia, which is in colloquial terms male pattern balding. Okay, so what that means in essence, let me try and do it in simple terms. When men use these products, the amount of product they use typically places them in a situation where they find themselves at a tipping point as they raise the dose, where they're trying to balance the efficacy of the clinical therapy, in other words, the outcome that they desire, against the consequential toxicology of the drug. The more you use, the more it works, but you get to a tipping point whereby the toxic side effects start to present and you have an area of diminishing return. And as I said, women, due to the fact that they're so exquisitely sensitive to these compounds, can operate at levels that are so far away from those dosages, okay, that they don't need to be forced up against reckoning of the same types of problems that men do in our domain, okay? Much, much smaller dose, different problems. That doesn't mean, it's not fair to say that you should ignore those issues, but you can view them through a different filter. In other words, if you're a woman and you successfully avoid virilization and masculization through strategy, through deployment strategy, it's a fair and reasonable assumption that you have done that through a methodology that will also protect your kidneys and your heart and your brain, right, from the consequences of the application of these drugs. This is very, very reassuring and very good news for women. Okay, so in short, the problem that we're trying to solve for here with women isn't the damage to your heart or your brain or your kidneys. That's not the primary concern. Yes, that is certainly something we need to be mindful of. Yes, it is true that if you cross the supraphysiological barrier and you're profoundly impacted by male secondary sexual characteristics over time, you certainly cross into that territory, but there is a threshold through which you must pass first, and that is the impact of male secondary sexual characteristics of these drugs, okay? As I said, acne, hair growth, various virilization outcomes, deepening of the voice, etc., like that, okay? These are the primary issues that we're trying to avoid. Now, this fine young man is a man by the name of Michael. Michael is a transgender bodybuilder. Michael was born as a female. At approximately 29 years of age, Michael decided to make the transition to basically present or to live his life as a man, and underwent, with the supervision and support of his endocrinologist, a process of raising his testosterone levels effectively to that of a man, and deliberately and intentionally inducing the male secondary sexual characteristics like change of his voice and facial hair and consequential change to sexual anatomy and to body composition issues. Okay, now the first big aha moment that comes here is asking the very, very obvious question, right? So if you were a woman and you deliberately and intentionally went out to induce these effects, okay, how much testosterone would it take to realize that outcome? And this is a bit of a shocker for a lot of people, because most people don't realize that the amount of testosterone that is used in these treatment models is about 50 to 100 milligrams of testosterone a week. And this particular study is looking at the efficacy of the use of subcutaneous testosterone for masculinization purposes, and they're giving people 40 to 50 milligrams a week subcutaneously, and you can see consequential to that type of dose, these women are realizing testosterone levels in the 500-ish nanograms per deciliter range for total testosterone, which is very squarely right about where most endocrinologists are trying to place men on testosterone replacement therapy. So in this study, about 91% of individuals managed to get to that level, 500-ish nanograms per deciliter, using 45 to 50 milligrams of testosterone a week. That's not a lot. A lot of people are surprised by that. I know a great many women using testosterone that certainly don't seek that outcome, that start testosterone in the 15, 20, 25, and even 30 milligrams a week range. And the reason they start there is because they're given very poor advice very often from their partners, boyfriends, husbands, people they know, who basically take the very bro approach to say, well, listen, if men are using, say, you're in 150 to 200 milligrams a week, women produce about 10% of the testosterone, right? So we'll give you 15 to 20 milligrams a week. That's how they come up with the number, quite bluntly, because I have asked many times, how did you arrive at that number? Well, it's about 10% of what my husband takes. So let's basically look at the blood work from just two women here that I have dealt with over the years. I've dealt with many, many women with testosterone replacement therapy. The top one was a beautiful physique athlete, very attractive lady, certainly does not desire male secondary sexual characteristics. She came to me because she was experiencing, pretty profound hair loss problems, hair scalp loss problems, and concern over application. The very first thing I did was send her off for blood work, of course. And this is her total testosterone values that came back at 375 nanograms per deciliter. And that was a consequence of taking 30 milligrams a week of testosterone. The bottom one is much more recent. This is someone that I've, helped a little recently as a coach. And this particular woman was using 9 milligrams of testosterone a week at this reading. So we're at basically 2.78 nanomoles per liter, her reading, consequential to the application of 9 milligrams a week. And you can see where that places her outside of physiological range. The point here, the takeaway would be the amount of testosterone that women need. Okay, if that's 9 milligrams a week, 9, not 90, just 9, okay, you can get some insight into how little that must be. Now, I want to compare that to the group of women that suffer from a disease state called PCOS, okay? PCOS is a disease that has a number of different condition states, one of which is that women hyperproduce androgens. And so consequential to that, we find that women with this disease state have higher levels of testosterone, circulating serum testosterone, than the normal female range. So you can see here, if the normal female range is up to 1.8 nanomoles per liter, there are some women in the PCOS suffering community that can push all the way up to basically, let's call it 5 nanomoles per liter. Okay. Now, interestingly, the World Athletics Association very controversially agreed in 2011, recognized the fact that they need to have a model in place to allow female athletes with hyperandrogenic outcomes to compete with other women. It's not their fault they have this disease state. They shouldn't be banned from competition because they suffer a disease. And as I said, controversial, yes. They ended up basically coming up with a determination that said, look, as long as you're recognized as a woman legally, and as long as you have testosterone levels produced naturally below 10 nanomoles per liter, then you're allowed to. That's 288 nanograms per deciliter. So you can see here there is a disparity between the transgender community, the people who are deliberately and intentionally trying to induce these effects, are realizing that at 520 nanograms per deciliter, typical average dose there. You can see that women that are doing 30 milligrams a week are kind of scarily close to that, 374. There are some women out there that produce so much testosterone naturally that they're actually allowed to compete under World Athletics guidelines. Controversial, as I said, agreed, up to 288, okay? And even just 9 milligrams of testosterone a week has the potential to place you outside of physiological range, which begs the question, okay, so how much testosterone do women actually need for testosterone replacement therapy? And we're going to discuss that in a moment. Okay. So before we get to that, let me talk about where I'm drawing this information from, these graphics and what I'm talking about, and ask the question, so why is there such a perceived imbalance between the quality of the information that is available to women and the quality of information that's available to men? And is that disparity reflected in what we call the body of clinical or medical evidence? What data do we have to support our opinions we form on application of enhancement practices in women? Okay. And I want to try and point out and make a point here, and that is, it's not because the data is not available. okay? The two strongest areas of what I would call influence in this domain is what I refer to as bro law. Your husband, your boyfriend, someone you know gives you his opinion, and his opinion is formed on, you know, his observation, his experience. You can take perhaps a viewpoint that said, look, there's a step up from that, and that's the same mechanism, observation and anecdote from more qualified individuals, coaches, and more experienced users, agreed. But I would like to draw your attention to the fact that we actually have some really interesting data on the application of these drugs that specifically applies to women. Obviously, there are peer-reviewed and published studies on female athletes, both historical studies and much more modern. I mentioned the data from the transgender community. In my opinion, this is one of the best data sets that actually exists for women to look at in terms of what does what, because you have a group of women who are deliberately and intentionally under medical supervision trying to induce the very outcomes that you're trying to avoid. You should be very interested in, so what are they doing and what actually happens? As I said, we have data on PCOS sufferers and other hyperandrogenic disease states that cause elevated androgen levels. We have the data from the post-menopausal women community using, you know, testosterone replacement therapy, and that really equates to men and TRT clinical data. And then what we have is my area that I'm really fascinated by, and that is the fact that every testosterone derivative, or almost every testosterone derivative that has been brought to market since 1935 was actually developed and tested and marketed to what we would call the androgen sensitive. Let me just explain what that means. So in 1935, when testosterone was first synthesized, almost immediately they recognized the clinical benefits for the application of, you know, testosterone under certain disease states. But when they gave it to women, they realized that there was a virilization or a masculinization, you know, effect. And so they pretty much immediately set about trying to modify the testosterone molecules to retain those therapeutic benefits, but to remove the androgenic consequence, okay? And this is how we basically arrived at every steroidal SARMs that we have available to us. And the definition of a SARM is it's tissue selective, so it's more anabolic than it is androgenic, okay? So all the common steroids, the steroidal SARMs, primobolan, masteron, anavar, nandrolone, etc. There are some clearly that are like halotestin that doesn't fit into this category, but most of the steroids that are in common use in bodybuilding were actually developed and brought to market and tested and marketed towards women, not to men. We would more correctly say to women and the elderly, okay? Which is fascinating, because what that means is all of the data they collect in that testing process, most of it's done in women. And even the data from the non-steroidal SARMs market, which is the emerging, you know, selective androgen receptor market, that entire market is targeting the androgen sensitive. That's not targeting healthy young men. That's not who they're after. They're after a opportunity to provide a therapeutic beneficial medication to women and the elderly, okay, for a number of different disease states. And we'll talk about that data in a little bit. So in other words, we don't have a disparity of information. I would actually argue if we blend everything together, anecdotal evidence, human clinical use data, the science or the underlying mechanism of action of these drugs, and the literature that investigates the physiological effects in women, we are very well served to form quality opinions based on good quality evidence. The reason that quality data doesn't exist, I don't really know. I suspect it's because even though individuals over the years have attempted to create such resources, that they are, just like men, not well supported by the community. I created a post just recently on Facebook explaining, so I announced that I was going to create this website, and literally I had so many people say, oh, thank you, we need this site, we need this information, it's fabulous, can't wait to have it. And yet, you know, just a handful of people got out their checkbooks and decided to be supportive at $15 a month, which is, it wasn't price sensitive. Anybody in our community can afford that entry fee. $15 is not prohibitive. It's almost a case of, Look, I only want things if it's free, and you can understand the folly of hopefully creating high quality educational resources and making them available free. It's just not practical. So we shall see in the coming months how the tribe embrace and support this type of endeavor based on how they embrace and support enhancedwomen.com. Okay, so we talked about testosterone, how much testosterone is used to masculinize men. That gives us a benchmark to go, okay, so you don't want to go there, all right? You don't want to go into the natural physiological range of serum levels of testosterone for men, and you can realize the outcome at deceptively small doses, 45 to 50 milligrams. This is a absolutely insightful and fascinating study. If you've done any time looking at androgen research, you would be very familiar with the studies that were done in men quite a while ago now that looked at the application of greater doses of testosterone, 150, 300, 600 milligrams of testosterone a week, and what was the consequence of the application in terms of serum levels of testosterone, free testosterone, DHT, and all of many markers they looked at, including body composition and lipid skewing and all sorts of things they looked at. This, for all intents and purposes, is the female equivalent of that. In other words, we have a group of women, healthy women between 21 and 60 years old, that basically do not produce testosterone. This would be equivalent to taking a group of healthy young women and removing their ovaries, okay? And then asking the question, so how much testosterone would we need to give them so that we could realize normal, healthy levels of testosterone? You can see it's pretty straightforward graphically represented here, that you're bouncing against the thresholds of natural range in women at just 3 milligrams a week, okay? So some women at 6 milligrams a week are already into physiological range, and your takeaway here should be as simple as this. Wow, that's not very much. That's not as much as I expected. Most women and most men, when they see this, that have any historical experience with testosterone, are very shocked, because they kind of expected it to be, you maybe, as I said, 20 milligrams a week or 25 milligrams a week. No. In the same regard as when people say you have to start anabolic steroids as a man at 600 milligrams a week. No, you don't. 600 milligrams a week is so far out of physiological range. It's actually like, wow, that's a long way out, okay? Now, I'm not saying women don't use that much money. They do, clearly. But what I'm saying is that that's a long way out of physiological range. And there shouldn't be any surprises about the consequence of that action over an extended time frame. You should be going, I know exactly what I'm signing up for here, because transgender women are using 45, okay? All right. There's a whole bunch of graphical representations here about increases in lean mass, strength, fat mass, consequential elevation of hematocrit and cholesterol levels and HDL levels, fasting glucose levels, and changes to sexual anatomy. I'm not going to go into detail in this particular video. We will be addressing and answering questions about that study in the Enhanced Women website in great detail. I think it's a fabulous study. People should be intimately familiar with what this tells us about the application of testosterone in women and the consequence of that choice. I mentioned before, females with hyperandrogenic outcomes consequential to disease states like PCOS, massively overrepresented in the female athletics community. The elite female athletics community is massively overrepresented by women with these disease states. I'll give you one guess why. Because they're able to perform at levels that far exceed the levels of performance levels of natural women, because they have testosterone levels far in excess of that. If female normal range is 1.8 nanomoles per liter, even World Athletics allows women who are legally recognized as women to compete with testosterone levels below 10 nanomoles per liter, as long as it's not artificially induced through the application of testosterone. Cool. Okay, so the different needs of men and women in strategic cycle planning. This, in my opinion, is one of the great misconceptions that women have about the application of androgens, in so much as what peak value means is, let's just call it the total load on that day, the total amount of milligrams per kilogram of anabolic steroids you're taking on day one. Cumulative lifetime exposure hopefully makes common sense, where you go, okay, so it's not so much about the amount you're taking on that day, but if you added up all of the cycles you ever did over the course of your exposure, what would that milligram, or what we're clearly talking about many, many, many grams, what would that number be? So the reason, as I said, the problem we're trying to solve this here is, despite the fact that there are many, many, many clinical studies to look at where anabolic steroids were used in an on-label sense for women, that they were quote unquote well tolerated, it's also fair to say, okay, that when it comes to the use of anabolic and androgenic steroids, okay, there is a fairly large disparity between what we see in the clinical evidence in terms of side effects versus what we see in anabolic steroid recreational users in terms of side effects. And I want to explain why that is. This is a study done a long time ago, 1984. We're going to have a look at a study that was just recently done in 2020 in a minute. And they both tell us the same thing. In this study, small group of women, usually they're small groups of women, this is just 10 women, but the smallest exposure to the cycle in this study was just 10 milligrams of anavar a day. Sounds like a very moderate amount, agree? The largest cycle of the 10 female athletes was quite large. It was actually 785 milligrams a week, peak load during the last 4 weeks. So you can see the disparity here. The lightest cycle was 70 milligrams a week of anavar. The heaviest cycle was 10 times plus that. Okay, that's a big disparity. Okay, now the most interesting takeaway here is this, and that is, of the 10 women that were in that study, they basically asked about self-perceived side effects of the steroids, and they looked at things like voice change, facial hair, sexual anatomy changes, libido, menstruation, aggression, acne, etc., body hair. Now, the interesting thing here is, despite the fact that some of the women were taking low doses, the smallest was just 10 milligrams of anavar a day, 10 out of 10 women, 100% of women, okay, reported some effect on their voice, okay? 9 reported an increase in facial hair, 8 reported an increase in sexual architecture, we'll call it. And you can see here, that's a deceptively large number. Why is it that we have these studies in women that seems that these drugs are relatively well tolerated, but in our group of individuals, we seem to have a higher perceived side effect consequence? And there's a reason for it. And I want to talk about what that reason is right here. In this study, 2020, this time 16 females, inside this study is the answer to that question. And that is that the mean age of the women in this study was 30 years old, 31 years old. The mean age at the initiation or first exposure to anabolic steroids was 23, okay? But the mean average exposure was 8 years. And that's the kicker here, guys. 8 years of average exposure, okay? So what this tells us, and clearly any single study can be refuted. I'm not drawing this just from this study. This is just a study to add support to a position. Okay, there are many, many, many studies that ultimately contribute to this opinion. Okay, is that it's not only the amount that you take, it's how long you take it for. In other words, the cumulative dose. This is perhaps the best study that represents that in a graphical format. And again, we're going back to the transgender community, where they're able to demonstrate that 100% of women that undertook this treatment, well, very close, let's say between 96, 97, and 100%, close enough to 100% for all intents and purposes, saw a deepening of the voice at different protocols. So different women took different amounts of drugs, but they all ended up at the same point. And the reason behind that is it is absolutely reasonable and fair to say that as you raise the dose, these negative side effects occur more quickly. That's true. But it's also fair to say at at significantly smaller amounts of drugs, if you continue exposure for long enough, we all end up at the same destination. So you can see here in this particular study, and again, no one study is forming this opinion. It's study after study after study that says this. It's very, very difficult to argue with this point that says, look, the dose and the duration of exposure matters to women much more profoundly than it does to men. Okay. We have enough clinical evidence to put that on the table that you kind of really can't argue with that. You can argue, so what is that dose and how long? I have no problem with that whatsoever. Very, very difficult to state with any degree of extreme levels of accuracy what that outcome is, principally due to things like genetic, individual genetic response, the variability of different drugs that are used. There's a whole bunch of reasons that are going to basically change the factors to answer the question, so how much and how long? But the idea of, as a woman, you need to consider how much and how long. You just do. I think I'm not overstating when I say you are delusional if you think it's just how much, okay? 8 years of exposure ultimately is going to catch up with you. Now, this is, in my opinion, a really good example of a study that says that this looks at the viralization of the voice in post-menopausal women due to the application of the anabolic steroid Androgen, commonly referred to as DECA. And in this particular case, they started to see changes to the frequency of women's voices after 1 year of exposure to just 50 milligrams of Androgen a month. That's 12.5 milligrams a week. It's a very small amount. If you were to give a woman 12.5 milligrams of Androgen a week, after 30 days, would we expect to see this? I'll be honest with you, no. 2 months, no. 3 months, no. 4 months, no. Eventually, and in this study after 1 year, you're going to start to see consequence here. And that's the takeaway. The first big takeaway here is it's not just the dose, it's the total lifetime cumulative exposure to the compounds that can cause these outcomes. You must be aware of this. You must. Okay. So let's talk a little bit about compound classifications. I think it's fair to say that in 1970, when we talked about performance enhancing drugs, what we meant was steroids. Even to the point when people think about performance enhancing drugs, even today, people think steroids automatically, but that's not really true. There are dozens of classes of different compounds today that you can access. And some of these compounds, some of them are involved in the capability of inducing male secondary sexual characteristics in women. Typically, they are testosterone and its steroidal SARM derivatives. And those changes are dosage and, as I said, duration of exposure dependent. Those changes we would typically see involve the voice, hair growth, like on the face and body, potentially hair loss at the scalp, sectional anatomy changes, etc. But very importantly here, there are a list of other drugs that I'm not saying there's no risk attached to their use. That is not what I'm saying. What I'm saying is they don't have the risk of male secondary sexual characteristic change in women. So, for example, the drug clenbuterol and the other beta-2 androgenic receptor agonist, salbuterol, terbuterol, this class of drug, even though it's potentially a pharmacological fat burner and a hypertrophic agent in its own right, it certainly contributes to anabolic outcomes in women and to some degree men, but not profoundly so. Women are exquisitely sensitive to growth promotion. That drug does not cause, by its mechanism of action, secondary sexual characteristics. It does not. Nor do insulin sensitizers or insulin variants, nor does recombinant human growth hormone or the growth hormone secretagogues, nor do IGF-1 variants, nor is injectable L-carnitine, PPR agonists, myostatin inhibitors, thyroid medications, things like DNP and BAM, other chemical uncouplers. So in other words, there's a whole raft of drugs that doesn't do that. Now, what do we take away from that? We can start to create a first pass strategy of what we might potentially use as a woman in a strategic model so that we can minimize the effect of male secondary sexual characteristics. Okay. And you can see there's a class there I've put down as veterinary drugs and research chemicals and untested on human drugs. We're going to talk about how we might assemble those drugs in a cycle or a stack, if you will, using bro language for the application of women. Let me start with it very simply. You want to spend most of your career leveraging the tools that don't cause male secondary sexual characteristics, but at the same time being very diligent that you're naively exposing yourself to other risks. There are certainly drugs on that list that are high risk drugs, but they won't cause male secondary sexual characteristics. So you need to spend most of your career in that class of drugs, and on occasion, on a strategic basis, you would reach your hand into the basket of drugs that we would call androgens and deploy them fairly strategically. Very high level discussion. I'm not trying to be prescriptive here. I'm just simply explaining it. Let's say we had 12 months of the year. You don't want to spend 10 months of those in the androgen camp. Ideally, you would want to spend 10 months of the year if you were to stay on, like many people do all year round now. Many professional athletes don't even come off anymore, and I can support that. I don't have a problem with that, right? Under the right strategy, okay? You want to spend most of your year without any androgen impact above physiological range, okay? That means potentially the deployment of the drugs in the right-hand side, not the ones in veterinary drugs, but the ones that I mentioned that have, it doesn't mean they don't have risk profile, but not secondary. And then a little bit of time, okay, potentially maybe pre-contest if you're a power lifter, or pre-contest if you're a bodybuilder, dipping your hand into the basket of the compounds that we know work so well, but we need to be very careful in the way we employ them strategically so we don't end up with a large lifetime cumulative exposure range. Okay, so which of the anabolic analgesic steroids, we're just going to talk about anabolic steroids here, can be considered more or less female friendly? This is something that I do find very frustrating. People just don't seem to connect the rational logic here. Any drug that historically was developed and brought to market to service the needs of the androgen sensitive women, okay, the elderly, is a candidate here. Any drug that was deployed in women by doctors for a certain disease state that demonstrated itself to be well tolerated by women and to provide anabolic outcomes and potentially improvements in body composition, why would that drug not be on the table? It makes absolutely no sense that you wouldn't at least put the drug on the table for a discussion. That doesn't give it an automatically green light. It means we can talk about it. We can talk about the good, the bad, the ugly, okay? So these are the typical drugs that were developed. Testosterone is the base, the master hormone. Nandrolone, Trenbolone, Anavar, Anadrol, Masteron, Primobolan, Stanozol have all historically been used in human clinical use, including the drug Trenbolone, and the target market was the androgen sensitive. We will talk about Trenbolone in the material of enhancedwomen.com, but you will learn, if you don't know already, most people have no idea what they're talking about when it comes to Trenbolone. Trenbolone is a steroidal SARMs. When it was deployed in human clinical use, it was given to women under the indication of osteoporosis for one of these things, and malnutrition was another. It is a steroidal SARMs. It has been historically deployed in the androgen sensitive women and the elderly. Okay, we'll talk about that in great detail in future material. Okay, I want to talk a little bit about tissue selectivity and the current or the emerging market for non-steroidal SARMs. I just want to show you this graphical representation here and explain why, in my opinion, if you're a woman, you should be very interested in what is happening in the SARMs world. And if you're a man, you have no business there. There's nothing on offer in SARMs for men. So understand this firstly, that the drugs that you refer to as steroids are actually steroidal SARMs. Okay, they have a testosterone backbone, and they're modifications of the testosterone molecule with the intent of maintaining their anabolic or even improving, ideally, their anabolic profile whilst minimizing or reducing their androgenic profile. The very definition of a SARM. Now, and by the way, on the right-hand side, for anyone that's interesting, this black solid line is the androgenic impact of the drug testosterone. The black solid line on the right-hand side, where it says ventral the black solid line on the left-hand side is the anabolic potential of testosterone. The black line on the right-hand side is the androgenic potential. And you can see how these lines kind of like merge together. They follow a similar vector, a similar trajectory. And this is why testosterone is referred to as the comparator drug with an anabolic to androgenic ratio approximately 1:1 or 100:100. Like it's the androgenic impact is very similar to the anabolic impact. You can see the dotted line. We're not going to get into great detail here. The dotted line is Trenbolone. So you can see the anabolic potential versus the androgenic potential. You just look at the right-hand side. Look how low the androgenic impact of testosterone is compared to testosterone. Trenbolone is a steroidal SARMs. On the left-hand side, we have ostarine and LGD4033. I want to explain why these drugs are of interest to women and of no consequence to men. And the reason behind that is, if you understand that when they first started to deploy anabolic steroidal SARMs in females, they did so with a degree of success, but it's fair to say that all these drugs, all the anabolic steroids, still retain a degree of androgenic impact, some margin. The entire discussion around non-steroidal SARMs is trying to find ligands for the androgen receptor that effectively remove that very last vestige of androgenic impact. Okay, that is what the whole shift is for. They're trying to make drugs that effectively can replace the testosterone molecule and retain full anabolic potential and basically no androgenic potential. Now, if you look at that graphic, you can see the challenge here. As you raise the dose, okay, from 0, as you move across to the right-hand side of the screen, you can see the green curve shows the anabolic potential of the drug rising up. And you can see the red curve, which is the androgenic potential, rising up. And that is why, okay, that these drugs have no interest for men. They're useless for men, because at very, very low doses that women are exquisitely sensitive to, you can use such a small amount of ostarine that you are effectively still within the threshold that says, look, the androgenic potential versus the anabolic potential is better than Anavar. Okay, that's the interest for women. It has very, very, very little androgenicity for a very good anabolic outcome. Okay, but as you add more and more and more of the drug, you can see the androgen level rises up to the point whereby you might as well bloody use Anavar. Okay, it's a better understood, widely deployed, widely studied drug that's been in human clinical use for 60 years. Men have nothing to fear from Anavar beyond the side effects of things like reduction of HDL cholesterol levels and the usual, and potentially reduction of sex hormone binding globulin. So the point being here is that the whole point of developing these drugs is to try to make drugs that are somewhat similar to Anavar in terms of there is a disparity between the anabolic and the androgenic potential, but they're better at it. And it's fair to say that this class of drug meet that criteria as long as you keep the dose very low. But when you start lifting the dose, when you start raising the dose, you can see it's right in front of your eyes there, you lose the tissue selectivity. The drug slowly becomes more and more and more androgenic. This is why the studies on ostarine are done at 5 milligrams a day, and the folly of using 50 milligrams a day, and guys think they're still steroidal SARMs. They just have no idea what they're talking about. So we will talk about that in great detail in the Enhanced Women thing, but just understand, steroidal SARMs are very interesting chemicals in the androgen sensitive at very low doses. Increase the dose, you lose the tissue selectivity. This is very well documented. This is not a surprise. This is not my opinion. This is me reflecting on the body of evidence, the overwhelming body of evidence that we have in the clinical literature to demonstrate that. So some simple understandings about the application of androgenic steroids, anabolic steroids in women, okay? So the first one I would say is that you need to understand that all of the steroidal SARMs, nandrolone, masteron, primobolan, Anavar, Anadrol, right? Very, very roughly, okay, we would say that they are similar in terms of androgenic impact in so much as they are quote unquote well tolerated. Yes, I do agree that there are certain numbers that you see throwing around about anabolic androgenic ratios, but you must understand those ratios are part of the approvals process and they're done in rats. Okay, what is true in a rat is not necessarily true in a human being, which we'll discuss many times. And so first we have a bioassay. Typically then we'll have something called a HB assay, which is the application of that androgen in a living creature. A rat is the typical surrogate that we would use. And we can kind of kill the rat afterwards and weigh its organs and weigh its, like, you know, the levator ani muscle and make a determination about anabolic to androgenic ratios. But ultimately, these are waypoints along the journey towards putting them into human beings and seeing how they're tolerated. And it's fair to say, for the most part, these drugs are all well tolerated in women, but there is absolutely a dose dependency at play. In other words, the more you use, the more it hurts, which underlies the point of general understanding. One, you need to understand that 30 milligrams a week of the injectable drug Primobolan is a very rational starting point for women. I support that as a starting point, as I would 30 milligrams of Masteron, as I would 30 milligrams of Nandrolone. Now, stating the obvious here, hello, Captain Obvious, 20 milligrams of Anavar a day is 140 milligrams a week. Now, I know lots and lots and lots of women who take 20 milligrams of Anavar a day and they delude themselves that it's a small amount of Anavar, okay? I don't know anyone that injects 140 milligrams of Primobolan and walks around saying it's a small amount. It's not, it's a whack, okay? The androgenic impact of Anavar is no more or no less in general terms than Primobolan. They're both well tolerated in a dose-dependent manner. So do you think if you took 30 milligrams of Primobolan or Masteron or Nandrolone, how would that stack up against 140 milligrams of a drug that is somewhat similar? It's more, right? But for some reason that I have never managed to figure out, people seem to think that 140 milligrams a week doesn't mean anything, but 30 does. Don't delude yourself. You don't start or you don't call 140 milligrams of Primobolan a small dose in women, okay? That is not a small dose, okay? Yes, I agree. When Primobolan was in human clinical use in women, it was deployed at 400 milligrams a week, but it's still not fair to say 140 milligrams a week of any of these drugs, any of them, is a small amount. None of them, including Anavar, okay? We're going to talk in great detail about that as we move forward, as I said. You should also understand that in general, oral steroids and SARMs lower sex hormone binding globulin to a much larger magnitude than a parental administration, in other words, an intramuscular or subcutaneous injection. And there is an argument to be made that says lowering sex hormone binding globulin potentially raises free testosterone levels. So you not only have the potential androgenic impact from the drug that you're introducing, but also from your testosterone levels based on whether they're suppressed, you know, on a dose and drug dependent basis. So a drug like Anavar plausibly lowers sex hormone binding globulin and consequently raises free testosterone in a dose dependent manner. And that is true of SARMs as well. This is a rather complicated discussion. I'm literally just putting a flag in the sand. Understand, in general, oral steroids and SARMs both lower sex hormone binding globulin by a larger magnitude than injectable drugs, and lowering sex hormone binding globulin has the consequence of raising free testosterone. The consequence of raising free testosterone raises your potential your potential androgenic exposure. Okay. You should also understand that there are different pharmacokinetics profile in men and women. This is a study that was basically done in men and women where they injected both men and women. The women got 100 milligrams of Nandrolone. The men got 200 milligrams of Nandrolone. And the pharmacokinetics profile of those drugs were, you know, spookily similar. And the authors of that study actually argued that because of the physiological differences between men and women, the way in which we metabolize and excrete drugs meant that the men basically excreted Nandrolone or cleared Nandrolone from the system, if you want to use simple terms, much, much faster than women, which resulted in lower concentrations despite a larger dose. Takeaway, understand when you look at pharmacokinetics profile, they are different in men and women. Okay. This is a drug, a study that was done in SARMs, non-steroidal SARMs. And I show you this for only one reason, and again, to support this idea that if you're a woman, I have no problem with you having interest in SARMs. I'm not saying you should use SARMs. I'm saying I would understand your interest. But men, you have no place. The blue line here is the men, an increase in lean body mass. The red line is the women. So you can see what happened with the men is the women massively outperformed the men in terms of return. But most importantly, the men were given 4 milligrams of this drug a day, and the women were started at 0.35 and then raised to 0.15. So if you gave a woman 1.5 milligrams of this SARM compound, and you gave a man 4 milligrams of the same drug, the women would return a greater increase in lean body mass. Women are exquisitely sensitive to growth promoters, and therefore the class of drugs referred to as SARMs, I understand it makes sense for women, lower androgenic impact, very good anabolic returns, makes perfect sense, very interesting. Like to know more about that. Thank you very much. You have no business in this space if you're a man. These drugs are not being brought to market. These drugs are not being tested, and they are not being developed for healthy young men. They're being developed for the androgen sensitive. And if you are androgen sensitive, I agree, I support you. Okay, cool. Let's talk quickly about quality of supply, because I think it's fair to say most people would recognize that today we have a quality supply issue. Okay, agree. There have been a number of studies around the world where customs department that have seized drugs have sent those drugs off for HPLC, basically HPLC testing, to determine what is the quality and purity of those drugs. And there's been ones done in Switzerland and Germany and New Zealand and various places. This is a study where they basically took drugs from the Korean marketplace in 2014 and analyzed them. And the outcome was that nearly half of the samples tested were adulterated. Now, is this good or bad? It really very much depends on whether you think your glass is half full or half empty. And what I mean by that is a lot of people will tell you that you can't get quality drugs today. It's impossible to get. The drugs back in the day were better. Okay, now that's not true. What this study tells me, because I'm a glass half full kind of guy, is that half of the drugs were exactly what they said they were. In other words, if you were buying those drugs, you had a 50% chance statistically of getting exactly what you ordered. Now, the problem is obviously you need to wade through the sewer to get to the 50% that are good. I would be much more concerned about this if these types of studies came back and said, look, 10% are real, because then you're going, how the hell do you get to the 10%? The point being here is quality a problem? Absolutely. 100% agree. But you need to view it through the filter to say, look, about half the stuff out there is not what you think it is. But the good stuff is out there. And so if you are diligent and you're careful and you do your due diligence, you can absolutely, just like I do, get the real thing at very fair prices, but it takes a little work. I agree. When I first started, looking at enhancement tools, the journey from I don't know what I'm doing to supply, this was a journey that took people like a year sometimes. Today, we are emotionally impatient, and guys want instant results overnight. You need to put a little time into building relationships and building trust and learning, where you get things from, and just this idea that, someone reaches out to you on Facebook and sends you a link and you buy it and you're going to get the real thing. Quite bluntly, you're probably not. All right. Half of the products are not what you think they are. Half of them are. Your job is to wade through the sewer to get to the real, legitimate, high-quality product. Okay, so let's just talk simply about some examples of cycle design for women. I kind of want to start this conversation with this idea that says, okay, remember when I was saying about moderate use? Remember that 30 milligrams of Primobolan and 30 milligrams of Masteron, both of these drugs have historically been deployed in women. Both of these drugs have been tested in women at eye-watering doses. The largest amount of an anabolic steroid tested in a human being is 1,200 milligrams a week of Primobolan in women. The clinical dose of Primobolan in women was 400 milligrams a week. So if you were to ask me, okay, so what is a supportable dose in women at moderation? I would say 10% of that. 30 to 40 milligrams a week I can support. Okay. So in Masteron, it was basically, it has been tested. We have Masteron in oral format at 1,000 milligrams a week in women. And basically it was deployed in women at 300 milligrams a week. I think 10% of that is supportable. Okay. So 30 to 40 milligrams a week, 30 to 40 milligrams a week. Why are you taking 140 milligrams of Anavar? Because why? Because someone told you that Anavar was safer than Primobolan. 1,200 milligrams a week of Primobolan in women, 400 milligrams a week therapeutically. If you take 30 to 40 milligrams a week and you realize a anabolic response from that, that's about as good as it's probably going to get in the world of anabolic steroids. Okay. So don't make the mistake of thinking because Anavar has this reputation of being safer than it necessarily is. I'm not saying that Primobolan is better than Anavar. What I'm saying is I would rather you took 30 to 40 milligrams of Primobolan than 140 milligrams of Anavar. If you said to me, are you okay with me taking 30 to 40 milligrams of Anavar? Sure, they're both very well tolerated drugs. Right? For some reason, as I said, I don't know why it is, but people believe that Anavar is better tolerated in women than Primobolan. There's nothing to support that. There are no studies at 1,200 milligrams a week of Anavar in women. Yes, we have studies that are reasonably good dosages, but not at that level. When Anavar was deployed clinically in women, it was deployed at 140 milligrams a week, okay? Yes, it's reasonably well tolerated, but using the clinical dose, I would rather back off and use 10% of that. Okay, hopefully you understand that. So what I would consider to be very moderate would be the minimum physical, therapeutic, beneficial dose where you're seeing increasingly tissue mass and minimum androgenic impact. How do we realize that? Staying as far away from the clinical dose as we possibly can. 30 to 40 milligrams of Primobolan, Masteron, Anavar a week. Now, you may well say that's not enough. I understand that, but someone's saying that's where the discussion begins for moderate use. What does very advanced look like? I want to talk to advanced. This is a cycle that came from a woman that I'm kind of doing a little bit of education for. She's a powerlifter, not a bodybuilder, and this is not terribly unusual. So the cycle basically leads into a competition. Started at 20 milligrams a day, 7 days a week, 140 milligrams a week, and you can see the dose titrates up to 50 milligrams a day of Anavar stanozol combination, resulting in a total load for the week of 350 milligrams. Not particularly unusual to see this, but in my opinion, this is too much, okay, for a woman. You need to lower this dose and make up the difference by using some of the drugs that we mentioned before that have the potential to add to our outcomes here without adding androgenic impact, without adding male secondary sexual characteristics. In my opinion, using this much drugs in women, even though a lot of people would look at that and go, okay, I see this quite a lot. I do not consider this to be moderate. I would rather basically women looked at a model like this. Let me show you a kind of model, which is, and in this particular case, let's say we have an athlete that's going to compete. These are drugs that you could make an argument for. I'm not saying you're going to use them. You could make an argument for that these drugs potentially contribute to changes in body composition. And I would argue that I would rather see someone drawing a small amount of drugs from these classes of drugs rather than just that cycle we looked at before that was anabolic steroids. Now, I know she's a powerlifter, so it changes things a little bit, but not profoundly so. In other words, a little bit of anabolics, a little bit of growth promoter, a little bit of thyroid, a little bit of PPR mediator, a little bit of alpha androgenic agonist, a little bit of beta 2 androgen. In other words, a little bit of this and a little bit of that, in my opinion, is preferential to a large bolus dose of a single pathway towards your outcome. Okay, so this is extremely controversial. I have no problem with people that look at this and go, look, I'm struggling to get my head around that. But the reason they will struggle is because this is not how it's done. This is not moderate use. This is for more advanced women. I would say the first thing you would do is you'd send a woman off to get her blood looked at and see where she lies in terms of testosterone against the upper limits of natural range for women. Now, that's what you do with men. The first thing you do is let's see where your testosterone levels, and if he comes back and he has testosterone levels in the middle range, the very first thing you do with a man is you would slowly, incrementally begin to titrate testosterone up to the point where he is either at the limits of what's plausibly natural or just over that range. And then what you would do is you'd start to look at other compounds that potentially you would add to the table for improvement of fuel supply efficiency strategies. That means things like recombinant human growth hormone, strategic placed insulin, injectable carnitine, and you might even look at mind-muscle connection or nootropic drugs like alpha GPC. The point being here is that we haven't actually crossed the physiological threshold on any of these strategies. We're really trying to take someone who was less than optimal and turn them into what I would call the superwoman. So she's bouncing against the upper limits of natural range of testosterone. She's bouncing up against the upper limits of IGF-1 and growth hormone levels for a woman. We have strategically placed insulin, improving fuel supply efficiency strategies. And then what you would do at some logical, rational model throughout the season based on what her activities were, her goals are, you would introduce a number of drugs that were complementary to that process based on her goals and bring them in and bring them out sort of thing to complement that, okay? So drugs like clenbuterol and yohimbine obviously have the potential to, or clenbuterol has the potential to act as a hypertrophic agent in its own right. The beta-2 androgenic agonist pathway is a hypertrophic pathway, as it is a competent fat burner. And here we might introduce either steroidal SARMs or non-steroidal SARMs, but we're doing it on what we would call a testosterone base. And this is not commonly done with women. Most women start straight out the gate with anabolic steroids. Now, the problem with that is this. If I was to send you off for blood work and get your testosterone levels done, testosterone is the only drug that we have in the anabolic steroid family that if I was to administer a certain amount of testosterone to you, I can send you off to a pathology lab in a reasonable time frame and evaluate what the consequence of that behavior was in terms of how much did you create in terms of an increase in serum levels of testosterone based on your intra-individual genetic response to that drug. When you take any other anabolic steroid, although it's in theory possible to measure in a research setting, there's no way to be able to go and test that and to see where you lie. Now, I made a video today actually about the bioavailable intra-individual genetic response of Anavar. If you haven't watched that, I recommend you watch it because you can see in some individuals you have an average response, in some individuals you have a lackluster response, and some individuals will metabolize and utilize Anavar at such a rate that you would call them hyper responders. But there's no way that you can test that as a layman, as an individual. You can do that with testosterone. So as controversial as this is, one could actually make an argument to say, look, the escalation of testosterone levels from wherever you sit now to the upper limits of natural range for women is the safest possible model for women for one reason and one reason only, because it is the only drug that I can send you off. If I go, I'm just going to scroll back to the lady client I had before here. So she's following this, effectively following this model, right? So if we send her off for blood work, I'll just explain what we did here because this is a very interesting, tiny little case study for people. Okay, so this lady was experiencing some libido issues, what we would kind of refer to as like less than ideal sexual function, and a whole bunch of problems that were related to basically like horrible hormonal profile, horrible. So she had tried a HRT type therapy practice, right? Estrogen, progesterone, was unhappy with that model and had made a decision to start using testosterone in a TRT setting. Okay, so we started her at 5 milligrams a week and we titrated that dose to 6 milligrams, 7 milligrams, 8 milligrams, looking for effect, looking for subjective feedback from her about, did you see a shift in behavior? Because she didn't see a shift as she moved up by 1 millimeter increments, we kept on going till we got to the point where it's 9 milligrams a week. I said, that's enough. We're going to stop there, despite the fact that you haven't reported a significant increase in libido and sexual function, as it were. Let's go and see what your testosterone levels are so we can make a determination about whether we need to pull back from the edge or not. And you can see here, consequence of that blood work at 9 milligrams a week, we are outside of the range by a large enough margin that we made a decision to come back a few notches. You cannot do that with any other anabolic steroid. Only testosterone has the capacity for on-demand blood work testing to say the consequence of me taking this much of this drug, all right, shows up in this outcome. So 9 milligrams a week for this woman, too much. We can back away a couple of the notches to buy ourselves a margin of safety. If we were using Anavar, if we were using Nandrolone, if we were using Primobolan, that capability does not exist for laymen. Yes, in the laboratory setting and research setting, yes, but not for you and me at the coalface. So that's the argument that says because you can measure testosterone, it's actually plausible that that's the safest drug for women to use, because you can administer, as I said, 5, 6, 7, 8, no effect. Let's send you off. Let's look under the hood, see where you're at. That's a little high for my comfort. Let's back off a little bit. That's a big stick to wield in terms of safety profiling. The capacity to say, I want to look under the hood and see what the consequence of my actions, rather than keep raising the dose with no means of measuring it beyond, okay, now I'm starting to see side effects. We're able to make adjustments without needing to see side effects to make adjustments here. Very, 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 very powerful discussion. Controversial, yes. Is it the way it's typically done? No. Do I think you need to do this straight out the gate? No. But for advanced women who are looking to be in this game for a very long time, the idea of having a baseline of testosterone that you modulate and then having other complementary compounds come in, quite bluntly, I would rather you did something like that than something like this. I think the long-term ramifications are much more predictable and probably will present a better safety profile than just using anabolic steroids that cannot be tracked and using too much of them. Okay, so the last thing that I really want to talk about is some practical recommendations here for women so they can walk away tomorrow and do something about this conversation we had. And that is, let's go back to what we're talking about. I'm not saying that women don't need to worry about their heart. I'm not saying they don't need to worry about the kidneys. I'm not saying they need to worry about the brain. What I'm saying is that women are likely to see the problems of changes to their voice. Women are likely to see, hair growth or hair loss problems. Women are likely to see changes to sexual anatomy a long time before they start to see those other problems, cardiac remodeling. Why? Because the amount of androgens that they need to expose themselves to and the amount of performance-enhancing drugs they need to expose themselves to are much smaller than men. 1 unit of growth hormone is plenty for a woman, okay? 3, 4, 5 milligrams of testosterone is bouncing against natural limit. Not 1,000 milligrams a week. Some guy taking 1,000 milligrams a week, he has all these problems. 5 milligrams a week. I'm not saying nothing, but I'm saying you're going to see consequence in terms of viralization and masculization a long time before you start to see chronic kidney disease. Okay. So how do we measure, how do we manage, how do we track our concerns as a woman? The first thing I would do is take a leaf out of the mole mapping space, which basically says if you have a mole and you're suspicious about the mole, don't try and remember what it looks like. Take a digital camera and take a photograph of it so that over time you can see, what, that mole is changing. And then you can go and see a dermatologist and show him the photographs and he can say, yes, I agree with you. We need to take action on that. Don't try and remember things. So a couple of things. I would recommend that any woman that exposes herself to any of these drugs start using a voice pitch analyzer. There are a number of different ones on the market. These are effectively tools that are designed for the, let's call it the vocal artist community, singers and the such like, that allows you to basically record your voice and it maps it out in frequency pitching. So you then can compare it later on and see if you're seeing a frequency or a pitch change in your voice. A very interesting tool that very few women, I quite honestly know very, very few women that, even are aware of the concept here of measuring your voice, not recording your voice and listening to it back. You won't hear the change. Let the analytical software show you the changes in the frequency. Far more sensitive than listening to it with your own ears, okay? Your own ears, you'll get used to your voice over time. Other people will start to hear changes in your pitch, changes in your frequency before you will. A vocal pitch monitor will actually pick it up even before that. Second thing I would suggest, start taking photographs of your face, of your hairline, of body hair, so that you have a digital record of where you're at. Don't try to remember these things. And you can even take a photographic record of changes to sexual anatomy over time. One of the things that, when I spoke to Michael, I mentioned about Michael before, the transgender bodybuilder. Michael was surprised about the sexual anatomy, just kind of snuck up on him, didn't see it coming, wasn't aware of it. And then all of a sudden, bang, that was there. Was very aware. First change was her voice. Noticed, her voice getting deeper, and Michael now sounds very much like a man. Okay. We'll probably get Michael to come on and explain his journey, because it's a fascinating journey. and then talked about various changes to libido and things like that. But it was sexual anatomy, but it was one of the things that literally just came out of nowhere, bang, right? So take photographs of your sexual anatomy so you can track changes over time. So I know I speak very fast. I know there's a lot of information in this presentation. This presentation is not designed as a standalone, book education for everything you need to know about enhancement. It is, quite honestly, enough information to put some flags in the sand, to throw some threads out there to let you pull on to say, wow, there's a whole bunch of stuff that I wasn't doing, that I wasn't aware of, practices that, like I'm maybe following a little bit too much bro law here. And the intent of this material is to raise awareness for the site, awareness for my services as a consultant, and in general, awareness about the safer use of application of these compounds in women. Now, basically, enhancedwomen.com is open for membership. I would encourage you, if you watched this video and found it to be of value, that you consider becoming a member. Membership is $15 a month. My job, unashamedly, is to continue to make high quality and engaging and interesting and valuable content month after month after month, to the point where you don't want to stop your membership. You can stop anytime you want, of course, but my goal is to make, continued value to the point whereby you become, for all intents and purposes, a lifetime or a multi-year member. That's going to come down to me. My job is to make that content and to engage you and to provide you value. Your job is to, say, yeah, I've been looking for a resource of quality educational content on this subject for a long time. I will support you. I will join up for a month. Impress me. So that's it for today's, webinar presentation. I know that's a lot of information. As I said, I thank you for your time, and I look forward to you becoming a member of enhancedwomen.com.